Hi everyone, welcome at the AIDS 2020 virtual mode. It's Andriy Klepikov here. I'll be talking about global epidemic among people who use drugs. It's time for urgent reform. There are over 270 million people using drugs over the world. Among those, over 11 million are injecting drugs. And prevalence of drug use vary from region to region. And actually in some regions, like Eastern Europe, the prevalence is 7 times higher than the average globally. That's the region I'm coming from. In terms of drugs actually used, cannabis is the number one, then opioids with heroin as a major drug. We see also other drugs, including stimulant drugs, methamphetamines, but despite lower volume, the trend is going up rapidly. Looking at the overall drug use over the years, we see that over the last, say, 10 years, it's quite stable in regard to number of people who use drugs, also prevalence of drug use. And it shows that any repressive measures, repressive drug policies promising to stop drug use overnight with huge repressive measures, incarceration, etc., don't work. So we need to address the problem of drug use with the more sophisticated measures and response, like harm reduction. When we look at the illegal drug use routes, in particularly heroin, we see that it affects all over the world, the globe. And we see some regions on the drug trafficking, including African continents, all its parts. So, and it illustrates not only the drug trafficking itself, but actually the problems, how problems are moving, where the risks are high, risk of HIV infection at the first place and other bloodborne diseases. So it's very important illustration to show that it affects all over the world. Women who inject drugs are much more vulnerable than men. And we can see that proportion of women vary from region to region. It's actually very high in Asia and Eastern Europe and North America in comparison with other regions. But risks are actually equally higher in all other regions as well. The graph shows just numbers. And the risk is higher because of high level of violence, trauma, personal problems, involvement in the sex work, or history on incarceration. So all these factors are making women who inject drugs more vulnerable than men. When we look at the HIV epidemic dynamic, there are just several examples I would like to share. People who inject drugs are 22 times higher at risk of acquiring HIV in comparison with general population. 20 times higher. So that's how we measure the risk. That's why harm reduction is called harm reduction. We need to reduce these harmful risks. Another big thing that share of people who inject drugs and new infections vary from region to region. Overall, globally, among all new infections, there are 12% of people who inject drugs accounted for new infections. At the same time, in some regions, like Eastern Europe, this percentage going up to 40+%. When we look at the map, actually this percent is quite high in nearly in all parts of the world. So it's not just a region-specific problem. This is a global problem we would like to bring attention at the conference and address it. As I said, risk of acquiring HIV is much higher for women who inject drugs in comparison with men, especially for transgender women, especially for those with a history of incarceration and involved in sex work. People who use drugs are more vulnerable, sometimes sharing needles, sometimes injecting on the street in not hygienic circumstances at all, being in a poverty situation, sometimes being arrested and beaten by police. I would like to bring your attention to the photo on this slide, where you see how drug users are detained. Nobody among them has a gun or other weapon, but you see a policeman with his hand on the gun. And now the entire world is involved in the campaign, in the protests against racism. Black Lives Matter. Black lives of people who use drugs are at much higher risk. And we need to mobilize to protect those lives. We shouldn't allow injustice, racism, and violence to be applied for people who use drugs and other vulnerable groups. Sex workers, transgender people, men having sex with men. We have to stop this, and this is the right time to do this. On HIV, we see different trends globally. Amazingly, how different they are. In some regions, new cases are dramatically going down, in some dramatically going up. And in those regions, sometimes it's epidemics linked to drug use. Drug use, and we are not talking only about Eastern Europe or Middle East. In some countries, like on African continent, where epidemic is known to be generalized, there are sub-epidemics with really growing trends of new infections among people who inject drugs. This is very dangerous trends we need to take under control, oppose. And for this, we need also to remember about economic, social, and health consequences. This is the cost of inaction. We know that harm reduction is one of the most cost-effective interventions globally. At the same time, cost of inaction is measured not only in human lives, but also in huge losses for economies. We know what works because it's needles and syringe exchange program, which is known in many countries and applied mostly through NGOs, non-governmental organizations, through community outreach work. And we know that opioid substitution therapy also works as a treatment and as a prevention. But what doesn't work, we don't see this at sufficient scale. We don't see this in all countries over the world. At the same time, quite critical to highlight that only in case of bringing these harm reduction programs to sufficient scale, to provide services to at least 60% of the most vulnerable groups, including people who inject drugs, this can bring the epidemic down. What we see from Ukraine, when we managed to do this, new cases went down. We need this for other countries as well. And we need this not only for the reason of harm reduction, we need this also to improve treatment cascade, 90-90-90. We see how different figures for people who use drugs, clients of harm reduction services and non-clients. The level of engagement in treatment It's really critical to engage people who use drugs in the harm reduction services with much higher benefit, including improvement treatment cascade. We saw how scaling up in China and Iran, in China in particular for methadone program, also helped to bring epidemic under control. At the same time, with interventions, we need to be dynamic. We see how drug patterns are changing. In my country, it used to be opioids, heroin, and domestically produced heroin. Now it's different. It's a mixed drug use. People who use drugs used to mix drugs. So in terms of the interventions, it cannot be a replication from the past. We need to be up to date with a response. People who use drugs having access to services, it's really unbelievable that only 1% of people who use drugs live in the countries with sufficient scale of needle and syringe exchange program and methadone program. The remaining 99% living in the countries with not sufficient service provision. It's terrible. It should be changed. It shouldn't be like this, because that means insufficient access to antiretroviral therapy. It's shame how disproportionately lower access to ART for people who inject drugs. It's a shame how little commodities they can access, needles and syringes. So this should be changed. It should be reviewed and it should be invested more. And we know the major service package, which defined by UN agencies, agreed with PEPFAR. We know what works, supported, but it should be not taken for granted. Because sometimes services are not available because of the legal barriers, human rights related barriers, and gender linked barriers. That should be changed through legal reform, through eliminating criminalization and removing stigma. And both UN agencies and global institutions such as Global Commission on Drug Policy playing great role in addressing this, maintaining high-level dialogue. It's also important for countries to learn when we introduce harm reduction at earlier or later stage, how different the impact is on the HIV epidemic. We see the countries neglecting harm reduction, such as Russian Federation, experiencing huge percentage of incidents, HIV incidents among people who inject drugs. At the same time, this percent is so low in countries of Western Europe, and we have also promising moderate example in the countries which introduce it even at a later stage, but still much better than doing nothing. In terms of the partnership, multi-country partnership is critical, learning from each other, learning from different continents. And a great example is set by the Frontline AIDS, uniting NGOs from all parts of the world, addressing harm reduction in their regions, mostly with the support of the Global Fund, so far the major donor for harm reduction interventions. Another great learning tool is the Harm Reduction Academy, the learning platform which helped participants from over 50 countries over the world not only to learn about harm reduction, but apply in their countries, starting harm reduction programs from scratch, relying on their knowledge, on the partnership established within the Harm Reduction Academy. Another big thing is responding to the latest trends. Like example, we are showing with the party box party box for those who are partying and planning to have chemsex. Yes, we developed a special kit which even includes drug testing things and all necessary equipment. That's the people who were underground, who never contacted harm reduction services, now looking to get these kits. So they're actively searching for contacting us. That's the way to go with the younger generation, adolescents experimenting with drug and sex. Well, with mobile van, we even don't need to put an advertisement. Young generation looking at the design of the van, going to enter themselves, looking actively for the information and for support for access to testing. With the mobile application, it allows 24/7 advice, support in critical situations like overdose. Applying technology, using mobile apps also to increase testing, to enroll new clients, and it helped to identify, it helped to increase yield, testing yield from 1% all over to 12%, which is an incredible step forward. Applying artificial intelligence and machine learning helped identify the most effective potential clients to distribute coupons for bringing people at the higher risk to use social networks. We used to rely on human brains, but sometimes machine learning, and it's proven, brings us to better results. That's the innovations which should be introduced in harm reduction. It's not only old school. We are experiencing up-to-date harm reduction services. Another big thing, linking TB and drug use. We understand that they are so interconnected, but when we look at the medical infrastructures, there are two worlds not talking to each other. So it's critically important to introduce TB-related services in the harm reduction programs, starting from screening, but then referral to treatment. It's also critical to have drug user-friendly facility in TB clinics, for example, access to methadone, that for active drug users, the only way nearly to be on treatment. There are other things like bringing humanity to the world of harm reduction. Sometimes it's not only about syringes, it's not only about condoms. It's supporting, addressing people's need. If it's a homeless person, we need to provide warm clothes. We need to provide bathroom facility. And this is a great example from Rio, where local community supported people who use drugs there, not only addressing their health need, but actually changing their lives for the better. And this is a critical element of harm reduction as well. COVID-19, we all know that it's impacting our world, and harm reduction programs are not an exception. We see interruption of services, delay, etc. At the same time, there are some things we are happy about. Yes, we even develop an interactive map showing what kind of things, innovations started in the time of COVID we would like to sustain for much longer than the COVID will be with us. Those are, for example, take-home dosages of methadone. We could hardly dream about this, that over 90% of all patients on methadone will get their methadone as a take-home dosage. 90%, unbelievable. Yes, we would like to keep it. Another thing is better situation with incarceration and with the police violence. Maybe It's because we have less people on the street, but the level of incarceration for petty crimes reduced substantially. We have sometimes even a better engagement for syringe distribution with secondary exchange. We have better online contacts with clients, so it's not necessarily only face-to-face meetings. So there are some developments we would like to keep. There are some recommendations we are interested to share and to provide with others. At the same time, there are risks of human rights violations, so it's critically important not only to monitor, but to address those. I would like to conclude with setting new trends for harm reduction. New context, new drugs, these require a new response to address fentanyl, spiking, chemsex, other emerging issues. We cannot deal with this with the old methods. Secondly, donors are leaving, and governments are not willing to support harm reduction. For them, it's a marginal issue. So a lot of effort should be invested to build partnership and to ensure that harm reduction will be funded, including from the governmental and municipal sources. Drug use is not a standing alone issue. It should be part of public health, including broader issue of mental health, including addressing broader range of issues like co-infections, etc. Policies. We know that repressive drug policy can cause only damage. Without eliminating stigma and discrimination, without decriminalization, we cannot further effectively address drug use issue. These policies should be changed. Another big thing is the human dimension of the harm reduction. We are not working with people who use drugs. We are working with people at the first place. And person-centered approach should become more and more important, addressing holistically the people's needs. And finally, it's not only face-to-face. We are more and more moving to virtual modality. Our conference is virtual, and distant support, online consultation, telemedicines, using technology, apps. This is the future. This is the future we will bring harm reduction to the new level. Thank you very much.
Thank you, Andrei. Thank you very much for this truly comprehensive and thoughtful overview. Good evening, good morning, good afternoon, everyone who's watching or listening. My name is Mishel Казачкиным. I'm a former executive director of the Global Fund and a proud member of the Global Commission on Drug Policy. And it's really a pleasure, Andrei, to now start our live discussion with you. I listened carefully to your presentation, and it's clear that we're still significantly off track when it comes to the UNAIDS target of reducing HIV infections among people who inject drugs. Progress is marginal globally. Progress in the access of people to harm reduction, to overdose prevention, to HIV and TB and hepatitis services. So my first questions would be, first, can you identify some specific areas of significant progress that could help us design better strategies? And then on the opposite, what would you say are the main challenges now? Where are they? Are they at the level of policy and legislation? Are they at the service delivery and healthcare level? Or are they still, and how much are they still relating to stigma and discrimination in society?
Thank you, Michelle, for these questions. Well, looking at harm reduction 5-7 years ago, I could hardly name any African country running harm reduction program. But now, both on east side and west side, also in Southern Africa, we see really working harm reduction programs offering syringes and opioid substitution therapy programs, other services. That's indication that things are moving forward, even in the challenging environment. Another big success factor is bringing harm reduction programs to scale, where they can really make impact on the epidemics, like in Ukraine, or example of scaling up methadone program in China is also quite impressive. There are other examples, of course, in developed countries proven with time its effectiveness. Technology is a big thing also to get applied more in addition to the human brains and skills and humanity. And at the same time, there are some challenges, and the most substantial one is repressive policies, criminalization, ideological barriers which are limiting evidence-based science, which is harm reduction is. Those barriers are really critical to overcome. Another big challenge is the funding. We know that harm reduction is one of the most effective interventions in the AIDS response. At the same time, with donors leaving many countries, there are growing gaps or risks in gaps in funding harm reduction.
Yeah, thank you. So the best examples you mentioned is actually harm reduction starting in places where it wasn't even like 3 years ago, and then harm reduction being scaled up. And I think the example of China is really something I would support very much. It's just remarkable how that country, which 10 years ago or 15 years ago was opposed to methadone, scaled up dramatically. And then the challenges, and we'll come back to that, inappropriate drug policies, non-evidence-based drug policies, ideology, and lack of funding, which basically comes from inappropriate thinking about drug policy. Let me stay in that area of drug policy, and I'd like to quote Kofi Annan, one of the founding members of the Global Commission. He said, and that's a sentence that many of you will have heard, I believe that drugs have destroyed many lives, but wrong government policies have destroyed many more. But he then added, when addressing the World Health Assembly, a criminal record for a young person for a minor drug offense can be a far greater threat to their well-being than occasional drug use, and that in many parts of the world, drug users are stigmatized, live under constant threat of arrest, and prevented from seeking treatment and support. So you haven't been talking much in your presentation about the justice system and law enforcement. And so I'd like to ask you, have you actually seen examples in the last few years of positive changes in the attitude of judges, courts, law enforcement, or changes in the discourse? Would you agree that decriminalization of drug use and possession and of minor drug offenses would be really the key policy achievement that we would all like to see? And then building on what you said on COVID, Do you think there is an opportunity now, when the COVID pandemic has also led to large, I would say, massive de-incarceration of minor drug offenders? Is this the right time to reopen the debate on the inanity and the harms of incarcerating people?
Absolutely, fully agree. Well, let's look at the latest UNAIDS World Report on the section of for Eastern Europe on legal drug policy. We see that the scorecard is really red. This is a red flag for all of us that the policy should be changed, because actually those policies are the major barrier for effective harm reduction. And this is the right momentum, absolutely. With COVID-19, we are facing not only risks and negative implications, but some opportunities, including with amnesty, quite substantial, like in Myanmar, for example, reducing arresting for petty crimes. Those are achievements, actually, we need to build on and sustain beyond the peaks of COVID. And in addition to changing the practices, there are even examples of the law change. In Ukraine, just a couple of days ago, starting from July 1st, law was changed, and there is no more incarceration for drugs possession.
Congratulations to Ukraine on that. Hopefully it won't change in the future, but that's remarkable news. So let's stay in the region. We have just a few minutes left. We've spoken about Ukraine, and you presented quite compelling information and data. Could you just elaborate a bit about the broader EECA region beyond Ukraine? Which areas of progress and which alarm bells, would you foresee in the next 2 to 3 years in Eastern Europe and Central Asia?
Of course, in our region, epidemic mostly driven by the situation in the Russian Federation as the largest country. And unfortunately, both two interventions, needles and syringe exchange programs and opioid substitution therapy programs are NSP exists at very limited scale, and OST doesn't exist. So this is a great signal to make changes. Otherwise, progress is nearly impossible. In our region, 48% of all infections linked to injecting drug use. So we cannot move forward without these changes.
And you're talking about changes. Sorry to interrupt. You're talking about changes. Could you tell, where do you see advocacy efforts? Where do you see the advocacy efforts to go? To government, to Ministry of Health, Interior, at national level, or maybe at city levels or province level?
Yes, from our experience, we need to push in different directions, but one of the inspirational example is changes at the city level, at the level of mayors who became agent of changes with very innovative approaches such as safe consumption room. Just a couple of months ago, mayors of 5 cities from different countries of the regions agreed to set up this safe consumption room. This is amazing examples how things can be moved forward even with generally conservative legal environment in the countries. Like we observe also in United States, yes, some changes are happening at the city level or states rather than the entire country. Well, another big thing is transition. Donors are pulling away from our region, so it's very important also to work with national government to ensure that these programs would not stop. It's critical to mobilize efforts of all stakeholders, including donors and UN agencies, civil society, really to ensure this.
Thank you very much, Andrei. I think it's about time to end this discussion and this session. I'd like to end it where you started. That is the urgency and the importance of drug policy reforms. Drug policies that should be grounded in, as you said, in scientific evidence and a deep concern about health and human rights. So thank you very much, Andrei, again. And thank you to all of you for listening and watching, and have a good night or a good day or a good afternoon, depending on where you are.
Thank you, Michelle, and thank you all AIDS 2020 participants.